Talk of today's conference has been this guest here, and of course it is my own medical director, Dr. Maia Dorsett. Maia, you gave an outstanding presentation this morning, and you've attracted a lot of social media, a lot of comments, and just start off by just giving us the sort of 2-minute resume of what you talked about, and then I've got some very specific questions for you.
Okay. I would say there's a few big ideas. The big idea is that we must be examining our diagnostic errors in EMS. The patients where we don't diagnose the problem are the patients with the greatest capacity for harm, because they're not getting sort of the bundles of care that are important to their outcomes. And that's going to require bidirectional information flow, but also improving the assessments we do for patients.
So even back in my day in the UK, MPDS, Medical Priority Dispatch Code 17, MPDS 17, falls was the largest category of call. And of course, I always talked about it's actually a gravity issue, and you mentioned that on stage today. But falls isn't just a pickup. It's more serious than that.
Geriatric falls are one of the most medically complex calls that we go on in EMS. And that's because not only do we have to overcome the low acuity bias of a dispatch that tells us what to do with the patient, but a lot of these patients have a lot of medical comorbid conditions. There's a lot of reasons that people end up on the floor, and we have to be able to do really thorough assessments to pick up significant medical illness such as sepsis, CHF, all these other reasons that cause somebody to be weak and end up on the floor, while balancing the potential harms of an unnecessary transport. So compared with a lot of other things that we sort of tout as important components of EMS, we do this a lot, and it's imperative that we do it well, because this is a very vulnerable patient population that has a lot to lose if we don't.
And I think you've framed it up beautifully, because many people may well go, oh no, here we go, another pickup. But actually, the way that you just explained that, and you asked everybody in the room to put the hand up if they've been to an MPDS 17 or a fall, and it's been a cardiac arrest. And actually, I was one of those. I've been dispatched to a fall, and actually, the fall is the descriptor of what happened, not what's wrong with the patient. Yeah, certainly, why are they on the ground? Because their heart stopped. And so it's something that I think you've brought really great attention to.
I think we always have to look to see what is the objective information we have, right? So when we are dispatched to a seizure, we objectively know that somebody was probably shaking and they were probably unconscious. When we're dispatched to a fall, we know objectively that there is somebody on the floor who had to call 911 to get up, right? Which is not normal pathology. And so that's what we objectively know. So we have to do the detective work of really good clinical assessment to understand the why and determine who is safe. And I think the potential to do good is really incredible, because there's lots of things that we focus a lot on doing well that are very rare events in EMS, and those are important, right? We have to be able to respond to the rare high acuity events. But if we could improve, even by a little bit, how we take care of these patients, there is a tremendous amount of value.
Right, and pun intended here, I'm going to pick up on something else around falls, but we, whoever the we are, we pick up the patient, we put them back in the chair and think that's it, but it's not, is it?
No, we really need to be doing thorough assessments, and I think one of the key components of the assessment is assessing their ambulation and mobility. So even when it comes to not just for home safety, but for the detection of medical illness, right? A lot of these patients are weak because they're septic, or they're dehydrated, or they have renal failure, or there's something else going on. And very often, as I've read a huge number of these and done work in quality improvement, one of the most commonly under-assessed things is whether or not a patient is able to get up from the recliner you put them in, get to their walker, and be able to walk to the fridge. And when I look at the repeat calls that happen in this patient, very often it's like turning the chapter of a chapter book. The first chapter ends with a patient being put in a recliner. The next one starts with that patient in a recliner. Later in the day, the next day, 2 days later, in much worse condition, because nobody went ahead and did that really thorough assessment. Not because they didn't care, but because that hasn't been the standard practice of saying, it is an essential component in every single patient who has ended up on the floor to make sure that they are able to get out of that recliner, get out of the bed themselves, because then they can't make it to the bathroom, they can't take their meds, they can't do all those things. And you're also verifying that they have the perfusion, right? The blood pressure when they stand up, the the lack of hypoxia when they ambulate, to like make sure that something more significant medically is not responsible for why they're going on the floor. And you can't always rely on clinical history, right? When somebody doesn't want to be sick, doesn't want something to be going on, their brain will fill in a story of I must have just tripped over that rug. But it is up to you to do that really thorough assessment to make sure that you're not missing something that is time critical, like sepsis.
Excellent. Well, the good news is that EMS1's editor-in-chief, Kerry Hatt, was in your session. She's actually written an article already, and so that's going to be posted on the website. We'll make sure that goes in the show notes, so you can see Maia here. You can read about her from Kerry's article that by the time that we get published, it will already be out. This was your first Pinnacle, Maia, and I think, again, excuse the pun, we've all fallen for you because it was a great presentation.
Well, I feel very privileged to be here and share sort of what I've been thinking about with leaders from EMS across the country.
Great, thank you. Well, we'll see who we can find next, but Maia, thank you.
Of course.